Hi, evening friends, evening everybody, bache. I guess we know each other pretty well. I'm Dr. Sushant and
I'm
with
Dr.
me.
Saurabh. So today we have come on Alan Next YouTube channel. So to start with some important integration in subject of pathology and surgery, you know, nowadays the trend has changed and we get a lot of questions which are integrated. So integration is the crux of the, you can say, the upcoming exams and especially INI-CET. I think, sir, you will also agree to this.
Totally agree.
And yesterday we had already seen a very good session by Dr. Amit sir and Ashwin Ranjan sir. So today we will start with this series without wasting much of time. We shall start the.
Let's start. Let's start.
So this is the first question, sir. Will
So starting with that, a female came to OPD with redness and itching over the left breast, as is shown in this image. Now, histopathology is performed, which shows the presence of large pale vacuolated cells with round nuclei in the epithelium. So there are two things. Firstly, the minute that I look at the image, I mean, I have two main clinical DDs. It is either eczema or a case of Paget's disease. But what clinches the diagnosis for a pathologist is the fact that there are pale vacuolated cells with round nuclei in the epithelium. We'll be coming to the histopath image in 2 minutes, but the question itself is suggestive of Paget's disease.
So I would like when the patient comes, what is the first thing that we would be looking at? If you see the classical presentation, there is erosion of the nipple, and this is what is very important. So there is erosion. Along with that, there is encrustation. So you know that sir will be explaining you the transdermal migration of the cells, and since all the ducts are connected with the nipple areolar complex, so nipple areolar complex is the first structure which gets excoriated, excavated on. So erosion plus encrustation along the nipple areolar complex, this is what is very important. And along with that, there may be discharge. So do you know that Paget's is considered to be the most common cause of nipple discharge from the surface? Now, one very important thing, like sir has already said, that it could be eczema. Now, this is what is very important. So, Paget's disease versus eczema. Now, these are two common diagnoses that we have. Now, the first most important thing is involvement of NAC. So, when we talk about the involvement of NAC, what is NAC, students? Nipple areolar complex. This is always there, and this might not be there. Then the concept of bilaterality is there. Paget's disease, it is not there. It may be, it may not be in eczema. Now the problem arises if it is eczema of the NAC. Nipple areolar complex encrustation due to eczema versus encrustation due to the cancer. Basically, Paget's is what? It's a superficial manifestation of underlying cancer. So in that case, if you go for a steroid course, so if you try to go a short-term steroid therapy, the Paget's, since it's a malignancy, will never have any response, but this will always have a response. And then students, once you are quite assured, you will take a biopsy and you will send it to the pathologist. So now sir, you explain the concept of.
So what we see, so there are actually two things. See, what is the significance of diagnosing Paget's disease? Because as sir had said that in 82 to 90% of the cases, it is associated with breast cancer, firstly, and especially if it is palpable, the chances of ductal carcinoma being present along with the palpable mass is extremely high. Now coming to the microscopy of the same, which you see the presence of these large cells which are present singly scattered as well as in clusters with a prominent nucleoli. Dekho, you are able to see large pale cells with prominent nucleoli in between. All these are the Paget's cells. All these are Paget's cells. Dekho, the difference between NEET PG versus INI is कि INI always gives you questions. They can, instead of giving, in this question, the question itself told you even without the image that it was Paget's, but it can be an independent image-based question also. So you need to, on the image, know that it is a diagnosis of Paget's disease.
And you should be knowing, when we talk about the concept of management, it's very important. When we talk about the Paget's disease, most of them are either associated with DCIS or maybe the invasive ductal cancer. But what is the standard of the management? So if you have a Paget's due to DCIS, it is either BCS or you can say a simple mastectomy. So majority of the time we go for BCS or the simple mastectomy. In case if it is associated with invasive cancer, in that case students, you will have to go for completion or you plan MRM upfront. So this is what is Paget's disease. And take home messages that you need to understand that the importance of Paget cells in diagnosis. And sir, I hope you will also tell them about some stains which are actually, so I think that stains, the past positivity. So what importance does it carry?
The minute we have the presence of clear cells with the, that means it has glycogen. So they are past positive, periodic acid shift positive, firstly.
So this is important.
Secondly, when we talk about the pathogenesis of the same, we see the presence of a duct which is involved by ductal carcinoma in situ. And the basement membrane is intact, and they migrate along the duct and come into the epidermis. These are the Paget cells which we were seeing microscopically in the slide.
I would like to highlight one point which sir has said, that they have gone into the epidermis. Remember, this is what is very, very, very important, because there's a difference between Pagets and a cancer with skin invasion. So this is just like an alga floating over the lake or a water body. This is important because if the dermis is involved, then you will get to see PUD orange, because the dermal lymphatics will also be involved. So Pagets is superficial spread of the tumor, not infiltration of the dermis. So dermis is spared, it is the epidermis where it is involved. So now students will move to the next question.
Perfect, sir. So thyroid, INI favorite, matlab you need to know with respect to thyroid. So 58-year male with thyroid lesion on FNAC was posted for hemithyroidectomy. Histopath of the frozen section is given. What is the next step in management? So first let's make a diagnosis on histopathology, and then we'll of course go to the management. Now, the minute I see this, you are clearly able to identify that all these are nice thyroid follicles with presence of colloid in it. The pink colored structure, all this is colloid. Now, point to be noted here is it shows the presence of varying sizes of thyroid follicles. Some are very large, some are intermittent sized, whereas there is a predominance of microfollicles. All these small are the microfollicles. Predominance of microfollicles makes it a case of follicular neoplasm. Now, how do I know whether it is a follicular adenoma or carcinoma? By capsular invasion, which is, this is the capsule. This is the capsule which is breached here, making this as a case of follicular carcinoma. Now, coming over to the management.
So thank you for that beautiful explanation, students. One very important thing that sir said, that follicular neoplasm. Merely on FNA, you cannot differentiate between follicular adenoma and carcinoma, because this FNA is just the aspiration of few cells from the tumor. So you cannot comment on whether it is adenoma or carcinoma unless you see the basement membrane or the capsule. Or one very important thing is that lymphovascular invasion. So sir has very beautifully defined that capsular invasion. But pre-operative, there are few important signs. So pre-operative, how can you conclude that it's a you can say it's a malignancy? This is also, there are some, you can say it's some insights. You might feel कि नहीं मुझे लग रहा है कि हाँ ठीक है, it could be malignancy. यहाँ लगने वाला कोई concept नहीं है. Remember, a follicular neoplasm. So pre-operative follicular neoplasm with the age of the patient more than 40 years. This is what is very, very, very important. And tumor size more than 4 centimeter. This is in favor of malignancy, and this is what is very important. Why this is important? Because if you try to be over smart and you think that, okay, I will do hemithyroidectomy for this patient, I will not go for total thyroidectomy. Remember, the management of cancer, if it is a malignancy, the only place for that organ is outside the body. So if it is diagnosed follicular cancer on post hemithyroidectomy, you will have to do a completion thyroidectomy. And remember, the first surgery at the level of neck, we are always afraid about the vital structures like recurrent laryngeal nerve and other parathyroids. Remember, the repeat surgery at the level of neck is always a disaster. So pre-operative planning requires a lot of things that we need to understand. However, merely, yes, you think that you are confident that, okay, this is this could be malignancy, this could be benign, you can go forward. So let me talk about the management of follicular neoplasm. Let me take that follicular neoplasm only in the diagnosis. Now, follicular neoplasm could favor adenoma also, and it could favor the carcinoma. Like in this case, someone favored, okay, this is an adenoma and he went for hemithyroidectomy. So either you can go for hemithyroidectomy. I've seen a lot of students always confused between hemi and total. Sir, when to do hemi, when to do total. The answer is, if you think it's a cancer, it's a total. Remember, when you go for hemi, only in case of benign conditions. So either you will go for total or you go for hemithyroidectomy. So when will you go for total? First is if the tumor size is more than 4 centimeters, you will go for total thyroidectomy. If the tumor size is less than 2 centimeters, you will go for hemithyroidectomy. The second is if the tumor size is more than 2 up to 4, now what to do, students? Now this could be a scenario where you need to see association with high risk factors or high risk features. What are the high risk? Remember the age of the patient more than what years? 40 years. So remember 3.8 centimeter lesion in 48-year-old. I will prefer to go for total. Remember, I can justify my actions. Next is same patient with size between 2 to 4 with a family history of cancers. So family history of thyroidal cancer, I will always go for. Third is like we have seen in this scenario, there is a capsular invasion. So if the capsular invasion is documented, this is what is very important. And the fourth is, which is very important, is lymphovascular invasion. Apart from this, students, you don't have to worry about. So this is what is very important for the management of the follicular lesion. So let us come to this question. A 50-year-old thyroid man with thyroid lesion, since the size was not given, okay, the question maker took the advantage of the diagnosis. What he did was that he did a hemithyroidectomy. But now, seeing the image, I would have always gone for total. So I would perform total thyroidectomy. Now, what about the concept of central neck dissection? Will we go for? Remember, follicular CA spreads by what route, students? It spreads by hematogenous route. And the dictum is, if you think that the lymph nodes are positive and I should be going for lymph node dissection, always check for the distant organs, they would be metastatic. And this is what is rule. So we don't require prophylactic neck dissection in them. Again, radioactive iodine ablation, we don't require radioactive iodine ablation. It's simply the surgery which is the next best management that I will be going for the total completion. So I would say it's a completion thyroidectomy rather than total thyroidectomy. Now, sir, would you show them, like you have shown a slide of follicular?
Actually, sir, beautifully explained with respect to the management part. I mean, crystal clear. Now, the questions that we get from pathology aspect of the same are, we have already seen follicular carcinomas. Now, previous 2 years, you have had 2 questions from thyroid microscopies directly. This is an image that I guess all the aspirants know pretty well. This is a no history slide. First, identify the parent organ. We are able to make out that this is a thyroid follicle with presence of colloid in it. That means that makes it as thyroid. Now, which are the cells that are present here? You are able to see the presence of a all these papillary areas showing orphan NEI nucleus. They are large clear nuclei. All the nuclei appear similar. Orphan NEI nucleus. Orphan NEI nucleus. She was a cartoon character and her name was Annie, and she had a large happy face like this. She was an orphan NEI nucleus seen in PTC, papillary thyroid carcinoma, PTC, which of course metastasizes by lymphatic route. As sir had mentioned, follicular carcinoma metastasizes by hematogenous route, which had significance with respect to the management part also. But a very important image. See, when we talk about this image, we are talking of NEET PG. Versus when we talk about this image, diagnosis. I'll be actually glad if you guys tell me the diagnosis in this. They look like follicles. So I'm leaning towards follicular neoplasm. But look at the nuclear appearance. They are large orphan NEI nuclei. That is making this as a case of follicular variant. Making this as follicular variant of PTC. Follicular variant of PTC has higher tendency for angioinvasion. They are angioinvasive in nature. This is PTC. PTC metastasized by lymphatics, follicular by hematogenous route, but the follicular variant is angioinvasive, and this is the image that we expect.
And students, can you tell us one more name for this tumor? And I would also suggest, like, hold my serotonin as given as a comment, that radioactive iodine ablation is performed in old age. Generally, we don't do radioactive iodine ablation because follicular cancers, they are devoid of colloid. The cancer parts are devoid of colloids. So generally, they don't have a very strong uptake tendency. So radioactive iodine is not having a strong role in the cancer management. Yes, you can say radiotherapy is having management management in treating the bone mets. The second is only the anaplastic cancers, or you can talk about the lymphomas where we go for radiotherapy. So yes, what is another name? Follicular variant of PTC. It's also known as Lindsay tumor. So the another name is Lindsay tumor, and nowadays you are also having one more name, that is encapsulated. So it's encapsulated variant, encapsulated follicular variant. The name is encapsulated follicular variant of papillary thyroid neoplasm. So many a times is EFVTPT, and I came across this word. I'm telling you, encapsulated variant. This is what is actually the follicular variant of papillary. People earlier used to think that it's a papillary cancer versus follicular cancer. Many people, there was a time when we used to consider that, okay, if more than 50% of predominance of papillary is there, so it will be
all that.
Yeah. So now there is nothing like that. This is totally considered to be papillary cancer.
Which this is not Hurdle cell. In Hurdle cell, you see the presence of large cells, abundant cytoplasm with, which is highly eosinophilic in nature. This is not Hurdle. Next, this was past previous year question, I think last to last year mid-year INI. It was given that it is a thyroid biopsy showing the presence of these cells. Now, these are sheets of tumor cells. All these blue cells that you are able to see here, all these are the tumor cells present in sheets. With this pink material, is it colloid? No, colloid has a finer texture to it. Versus here, which is slightly coarser, that is this extracellular pink material, which is amyloid. So which is the thyroid malignancy associated with amyloid deposition?
Come on, so it's a very easy question.
That is medullary carcinoma thyroid. Medullary carcinoma thyroid. Perfect. Next.
And students, I would just tell you 2-3 points about medullary thyroid cancer. It's very, very, very important for you to understand that medullary thyroid cancers have a totally different concept. They are neuroectodermal, arising from the ultimobrachial bodies ultimately. But there's a classical triad for medullary thyroid cancer. First of all, there is increase in calcitonin, point number 1. The second is there is increase in CEA. This is 1. What is the gene mutation? Come on, tell me, what is the mutation? This is what is very, very, very important.
Perfect answer.
Yes, excellent.
So,
red proto-oncogene mutation, red. So, if I will ask you what is red, it is rearrangement during transfection. That is what is red. So, red mutation with calcitonin increase, with CEA, and then there are some paraneoplastic syndrome related hormones. So, there is increase in serotonin, and hence there is diarrhea. Then there is increase in histamine, and hence that is associated with flushing and tremors. And there is also the increase in ACTH. So you get what the typical Cushing's like features, so Cushingoid features. So this is a classical pattern. And when you talk about the spread, it has a both hematogenous, it has lymphatic, and it also has a direct concept of spread. So this is considered very important. Now, the catch in this question is, normally we don't go for pre-operative CT or MRI in cases of the thyroid cancers. The exception to this are 3. First is medullary thyroid cancer to check the local resectability, as well as we need to evaluate the relation with the nearby structures. The second is, it is anaplastic, and the third is Hurthle cell cancer. Now you must be thinking, sir, why not CT and MRI? Let me tell you, post-operative, many patients might require radioactive iodine scanning and further treatment. So for that, we need to elevate the TSH level. And most of the contrast that we use for CT or MRI, they are iodinated. So already we need to have a phase where we need iodine deprivation, and you are giving a contrast which is actually loading the body with iodine surplus. So thus the abstinence phase which is required might be extended from 4 to 6 weeks to maybe 10 weeks to get the target TSH level sufficient enough to stimulate the remnant cells if they are present. So remember, that is the reason we routinely don't go for CT scan, because we might require a thyroid scan post-operatively, and there we require to cut off all the sources of iodine also and the exogenous T4, T3. So that abstinent phase might increase, and that is what is very, very, very important. But here you need to check the resectability. Now students, let me take you to the another question, sir.
That is an elderly patient presented with abdominal discomfort, and he was diagnosed as type 1 gastric cancer on Lawrence classification. You very well know that Lawrence histological classification, it is of, we divide on the basis of Lawrence classification it into 2 types. That is the intestinal type versus the diffuse or the signet ring cell type. You already know this. Now, which has worst prognosis? That is diffuse or the signet ring cell type. Intestinal type is type 1, diffuse or the signet ring cell is type 2. Signet ring cell associated with which gene mutation? E-cadherin. It is associated with E-cadherin gene mutation. I'll be actually glad if you tell me which other tumor of the body along with signet ring cell has E-cadherin gene mutation. I guess one of the favorite organs of surgeons. Next we'll write that in a minute. Next, signet ring cell, which is this is female predominant versus intestinal type, that is male predominant. So it is also associated with breast cancer. Which breast cancer? Lobular carcinoma breast. Lobular carcinoma. So coming on to this, which of the following is not true?
Now students, let me tell you something about this. Sir has already started this classification. I would like to add a few things like gender predominance we have seen, then association we have seen. This is associated with atrophic gastritis. So this is associated with atrophic gastritis and dysplasias. But this is associated with what, students? I've said signet ring cells. This is one thing. Then what else is associated? You must have seen fat, young, obese female, also obese female with blood group A. So many of the times you often get to see, students don't take blood group A as a risk factor, but it has been seen that yes, it has a higher predominance. One more very important thing is that nowadays we use PET-CT as the, you can say, metastatic workup tool. So when you talk about the PET scan, so do you know that intestinal type, yes, they are PET avid, but this is not PET avid. They are not detected. Why? Is this so? Like they will not have that Wahlberg effect and they will not take up that chlorodeoxy agent, whatever you have given. The answer is that, as the name suggests, it's a diffuse type. So there will be diffuse uptake, and this is not crossing the threshold where they are detected, and that is why they are PET non-avid. Now, since this question is based on on a lot of parameters, let us also discuss their pattern of spread. The intestinal type, if you talk about, they have hematogenous spread. And when we talk about the diffuse type, this is having the lymphatic spread as well as direct spread. And you must have heard of something which is known as leather bottle stomach or Linitis plastrica. What is that? That's again a diffuse type of cancer. So if you read this, which of the following is not true? More well differentiated, exactly yes. Associated with gastric atrophy, I have already discussed.
Agreed.
More common in males, sir has discussed. Lymphatic spread, no. This is what is very, 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 very important point. Sir, I hope there are some other classifications also, like Japanese classification.
Japanese classification is used.
So you can highlight in that, and then I will discuss in brief the management also.
Okay, so before we go to the name of the classification per se, let us have a look at the microscopic feature associated, because in this question the examiner had talked about type 1 gastric cancer. So you already knew that it is the intestinal type, but instead of writing it as type 1, the examiner can simply give you this image. Now, सबसे पहले tell me कि which part of the lesion is affected? Is it the upper part which is affected or the lower part? There are two parts here, the upper and the lower. Which is the upper part is normal. You see the presence of beautiful glands in which nuclear polarity is maintained. Nuclei is present on same side of the cell. It is the lower part which shows the presence of large cells, abundant cytoplasm with an eccentric nucleus. The nucleus is pushed to the periphery, which looks like a ring. This is signet ring. This is what signet ring cell adenocarcinoma looks like. This is signet ring cell adenocarcinoma. That is type 2 Lawrence classification.
So I would quickly go to one very important part of this chapter, that is what is the management of CA stomach. So you know, when we have diagnosed everything, we have done a metastatic workup. I'll just quickly brush up. It's beyond the scope of this session to discuss everything, but I'll quickly brush up. Remember, you know what is T1, T2, T3, T4. So it's mucosa, submucosa is T1, you know, things are like T2 muscle, T3 outside the muscle, not breaching the serosa, and T4 is breaching the serosa and going into the local structure. The lymph node, N1, 1 to 2, N2, 3 to 6, and more than 6. More than 6 is going to classify for N3. Leave everything. So suppose you have a patient of gastric cancer. So let us quickly revise it. The first thing that you need to ask is what T does the patient belongs to. So either it could be T1, N0, M0, or it could be T2 and above, point number 1, or students, or any T with N positive but M0. So what is the significance here? If this is the case scenario, the first thing that you need to go for is NACT. What is this NACT? You need to go for chemotherapy, and then you go for surgery, and then again you complete the chemotherapy 3 cycles. So let us try to understand what is this significance and what is this trial. Yeah, I hope you know about this MAGIC trial. So MAGIC trial has shown that patients in whom it is T2 and above cancer, and if we go for chemotherapy to reduce their, you can say, size or stage, this is what is very useful in creating a better disease-free survival. Remember, MAGIC trial says split the chemotherapy. So 3 cycles of 5-fluorouracil and cisplatin. This is 5-fluorouracil plus cisplatin is what we give, and then we do the surgery. There may be sometimes something which is known as complete pathological response also. The cancer might go away. Now, if it is T1 N0 M0, the next thing is you need to understand that whether it is T1A or whether it is T1B. What is T1B? Is into the submucosa. So if it is into the submucosa, you will have to do gastrectomy, treat it just like a conventional, you can say, the CA stomach. So here you are going surgery, you are doing is a gastrectomy. We will discuss that later. If it is T1A, the next thing is what is the tumor size? There are 2 questions, 2 things that you will ask. Is the tumor size less than 4 centimeter, and is there no lymphovascular invasion? So if the answer is yes, there is no lymphovascular invasion and tumor size is less than 4 centimeter, you can go for EMR, endoscopic mucosal resection, or ESMD, endoscopic submucosal dissection. If the answer to this is no, that means either the size is more or lymphovascular is, you have to treat it like adeno-CA. This is what is very, very, very important. So this is the significance of NACT. Much more discussion we will see in some other session beyond the scope of this integrated session, because we have other topics also to be discussed.
Comfortable. But for the students, I mean, do pause the session at this point and have a good look at this slide. I mean, you have actually in a single slide given the management part.
Next question.
So let's have a look at this. Middle-aged female presents with a painless lump in the breast. Mammography is showing suspicious microcalcifications. That means the examiner is taking you towards malignancy. Ultrasound shows the presence of large cells with the cytoplasmic mucoid globules and neighborhood calcification. That is, calcification is occurring around the lesion. And there was presence of mucoid globules, making this as a case of lobular carcinoma. So most likely diagnosis lobular carcinoma. Next, now the first option in this case was DCIS, ductal carcinoma in situ. Bache, important images. We can divide ductal carcinoma in situ into 2 types, that is comedo versus non-comedo carcinoma. This is not Paget's, this is not Paget's disease. See, there is no invasion of basement membrane, firstly. Second, fair enough. We will not think of Paget's on this. It has cytoplasmic mucoid globules. Firstly, neighborhood calcifications. These are the 2 main pointers towards lobular. It was not ductal carcinoma also, because it was not shown to have any cribriform pattern. I'll show you the images in just one sec. So, comedo versus non-comedo carcinoma. We divide DCIS into 2 types. Comedo carcinoma, of course, clinically it is the most common palpable DCIS. This is palpable. Versus DCIS as such again is associated with calcifications in the lesion. Now, non-comedo carcinoma is of further 2 types. That is micropapillary type. So let us first have a look. At the first lesion. Now, suppose nothing is given here except the fact that it is a breast biopsy. What do we see in this? We are able to appreciate the presence of large dilated ducts, which is filled with hemorrhage. All the red areas are hemorrhage and calcifications. Normally, a duct is 2-layered. We see the presence of bilayered cuboidal epithelium. Here the number of cell layers is also increased, making this as a case of comedo carcinoma, making this as comedo. And I guess, sir, we get a question in surgery also that all the carcinomas are invasive except comedo is non-invasive. It is ductal carcinoma. It is a variant of DCIS, ductal carcinoma in situ. Versus, now have a look at this. I know this is evening time. We usually munch on cookies or biscuits at this time. So, showing the presence of a dilated duct with large empty areas in between. What we Indians call as biscuits, English call as cookies. So, giving it the classical cookie cutter appearance. Giving it the classical cookie cutter appearance. Seen in cribriform DCIS. Seen in cribriform DCIS. And lastly is the presence of micropapillary DCIS. We see the presence of a large dilated duct along with the presence of papillae. All these are the papillae. How will we differentiate it from interductal papilloma? Interductal papilloma has a central fibrovascular core. What you see in an interductal papilloma is a papilla with a central fibrovascular core. You see the presence of a pink material inside it. This is intraductal papilloma. Versus in the image, there is no fibrovascular core. Central fibrovascular core is lacking, making this as a case of micropapillary DCIS.
So usually I send a lot of patient tissues to you, and I've sent a lot of breast tissues. But this was the first time actually I was listening to all those things and seeing it carefully. You always send that photograph, pic of that slide. True. So this time I was actually seeing it very carefully. Students, a beautiful discussion done by sir. I would just quickly discuss with you few important points in relation to the in situ tumors. So sir has described everything. I hope you know that in situ tumors are the tumors which are enclosed within the what membrane? Within the basement membrane. So suppose this is a tumor. So when we talk about the in situ tumor, there is a basement membrane and therefore there is no vascular access. Now you will say, sir, what is the significance of this vascular access? Since there is no vascular access, therefore there is no concept of what, students? Lymphatic spread, or you can say there is no concept of hematogenous spread. And this is what is very important. You will say why? Because since hematogenous spread is not there, therefore post-surgery chemotherapy, it has no role. And students, this is what is very, very, very important. There is no role of post-surgery chemotherapy. The second thing is that lymphatic spread is not there, therefore screening of axilla. So generally we go for axillary lymph nodal dissection. Many think that okay, the disease has gone into the axilla, that is why you're removing. No, students. Axillary dissection is having no therapeutic significance because there are 50 lymph nodes. We cannot remove 50. It is only having the prognostic significance. We need to sample the random lymph nodes. If we find significant lymph nodes, then that means the disease is not only contained in the breast, it has moved out into the neighbor's house. And thus we need to radiotherapy to fall on this axilla and completely kill the tumor cells, thus preventing the local recurrence. This is very important. Radiotherapy is not preventing the, you can say, systemic metastasis. It is preventing the local recurrence. So here there is no concept of axillary lymph nodal dissection. Now try to understand. Since this tumor is situated inside a basement membrane, and there is no concept of spread, I can say that I don't require a treatment for this. Answer is yes. But how long will it stay inside the basement membrane? This is important. So why we treat in situ tumor? It is not because we are fearing the in situ component. We fear the invasive nature. Many a times, there could be a time when you have detected in and you are monitoring and the patient goes invasive and metastasis. So why we operate on in situ tumors? Because today it is DCIS, but tomorrow it can convert into invasive ductal cancer. Now here is the key. I'll explain you what is the difference in approach between the lobular carcinoma in situ and ductal carcinoma in situ, because sir has described lobular cancer in situ. The next thing will what the patient will ask, sir, what to do now? What to do now? I'll explain it to you. So DCIS to invasive ductal cancer, the first question is, sir, how frequently will you see it converting and what is the time frame? So remember, it is 5 to 15 years. So the time frame is within 5 to 15 years, majority of the DCIS will convert. So what is this majority? More than 25 to 60% of them will convert, and thus we know that we need to operate on, and that is the reason why we operate on DCIS. So what is the classical management for them? Either you can go for BCS, or students, if post BCS residue is there, you can go for simply add radiotherapy to this. And if there are multiple tumors, instead of doing multiple BCS, you will go for simple mastectomy. Now you will say, sir, forget about that thing, tell me something about LCIS. Now try to understand, when we talk about LCIS, do we have that fear? Yes, we have that fear. And do you know that LCIS can convert into both invasive ductal CA also, more than invasive lobular CA. So this is what is very, 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 very important, that LCIS is not an anatomical congener of the lobular cancer. This is what is important. Next is, just see, sir, how frequently and in what time span? 15 to 25 years. Unlike the DCIS, which was getting converted in 5 to 15 years. That's a pretty short span of time, because many a times when you detect a lump, already 5-6 years have passed. So it takes 15 to 27 years, 25 years. The next is, hardly 5 to 15% of patients get converted. So it's a very small window. Not all of them. And do you know, more than 2/3 of the patients who are diagnosed with LCIS, they are more than 50 years of age. So majority of the patients, if they are detected, they are around 70-75. Students, what is the concept of oncosurgery? It is any surgery done with an intention to prolong the life expectancy. Here, students, the patient has already reached the upper limit of life expectancy. And that is why after 75, the medical comorbidities are such a problem that doing a surgery and their post-surgery chemo, radio, it's a very difficult task. And that is the reason majority of the patients don't even get to know. It is after death their autopsy was done, and you might find, so majority of the patient even don't get to understand that they have got converted into the cancer, or maybe the LCIS has just passed off. So remember one very important thing, because of their slow progression, point number 1, because of their less frequent progression, and this is the reason, therefore, the surgery is not a first line option. So what we do, patient, we advise, madam, you can go for active surveillance. So what is the management? We don't go for the straightforward treatment for LCIS. And if you see the risk factor for the CA breast, we have included LCIS in the histological risk factor for invasive cancer. So LCIS per se, don't say it's a benign condition. Because a lion is a lion, you see the lion in jungle or you see a lion in zoo. The only difference is the cage. So here the cage is the basement membrane. So you can click a selfie, but tomorrow if you come to know that the cage is open and lion can come out anytime, you will not take that risk. And that is the scenario with DCS. Here someone has told it's well locked. Every day I'll check the log. Same way, active surveillance is one thing. Or if you further want to reduce this risk of 1 to 5%, or you can say 5 to 15% to 0.5 to 1.5%, use chemo prevention. And what is that? You can use SERMs or you can use aromatase inhibitors. So that is the reason why LCIS has also been removed from AJSAC. So TLCIS is no more included in AJSAC 8th version, and this is what is very important. Don't say that it is no more malignancy, it's a benign condition. No, it's an in situ, but it's an in situ condition which is slowing. So we don't require it to aggressively manage. So what is the management? Active surveillance with annual MRI. So it's not detected on mammography, with MRI. So annual MRI is what we go for these patients. So I hope the LCIS and its management is clear.
And actually an important point, it's not detected on routine mammographies because calcifications are not seen in the lesion itself. They are peritumoral, as was given in our question.
So serotonin, I have already answered this question that LCIS is no more considered. Why it is no more considered? This is there, sir.
And talking with respect to the lobular carcinoma, I guess a simple straightforward image of the breast. Examiner just told you that it is a breast biopsy. Breast biopsy in the cases that LCIS has progressed to lobular carcinoma. We see Indian file pattern. The cells are arranged singly, giving this the Indian file pattern lobular carcinoma. If the cells are discohesive in nature, they are not associated with desmoplasia also. Desmoplasia is the body's response to the tumor. So these are non-desmoplastic. It is not associated with desmoplasia. as a result of which they are non-palpable also. They are non-desmoplastic.
So now we will go to one more question. Sir will read out a question. It's a very important question.
Pheochromocytoma. The rules of 10. Rules of 10, but I'll be glad if you tell us the answer in this. A, B, C, D. You know the rules of 10 with pheochromocytoma. But actually what happens is we know the content, but while marking the answer, silly mistake happens. So they 10% are extra-adrenal, 10% are seen in children, 10% are malignant, 10% are bilateral, not unilateral. So it was the other way around, 10% are bilateral.
So let me take you to pheochromocytoma. What is pheochromocytoma? You know it's a tumor of adrenal medulla, and adrenal medulla is associated with generally two type of tumors. The first is pheochromocytoma and then is neuroblastoma. So we have pheo or we have neuroblastoma. Let us try to understand something about this. So when we talk about the 10% rule, we know that the pheo are generally considered to be benign entity if found to be invasive and metastatic, then only. Remember, merely capsular invasion or invasion into the nearby structure doesn't qualify for being malignant. So approximately 10% of them are malignant. This is one thing. Then sir has already told you that 10% of them are bilateral. So if you see in this question, it is written 10% of them are unilateral. Then there is something which is known as extra-adrenal pheo. So what is this extra-adrenal pheo that I am talking about? Yeah, it's yes, they are known as paraganglioma, and this is what is very important.
It was one of the favorite PGI questions before INI formed.
And every year they used to ask this question. Now, when we talk about paraganglioma, what is the most common site for paraganglioma, students? It is again, come on, tell me, the students, you can tell me something like organ of Z, I can tell you organ of Zucker candle. So organ of Zucker candle is the most common site. Now why it is the most common site? Let us try to understand. So this is the most common extra-adrenal pheo, and where it is located, try to understand anywhere between the crus of diaphragm up to the bifurcation of aorta, they are found. Now what is the reason for this? Let me tell you. When you talk about the neural tube and from where the cells migrated, so there was a journey that everyone came to know, okay, that we are going to migrate and we are going to create the adrenal medulla. So the primitive, when we talk about the embryogenesis and the formation of the gland, there was a migration of cells, and these cells migrated, they settled down, and they formed what, students? Adrenal medulla. Now when the adrenal medulla was formed, there was a group of cells which was in transit, and then a wireless message is communicated ki ho gaya, theek hai, all the seats are filled, done. So where is this cell going to decide? Anywhere. So these cells actually contribute to the organ of Zucker candle, and that is why the most common site is there, located in that same transit area. And remember, it is the slightly left to the bifurcation of aorta where you get to see them. Let us not go into that. I will quickly ask sir to discuss this, and then I will discuss the management for you.
Okay, so coming to the microscopy, I guess a simple straightforward image, the Zellbellen pattern. It is showing the presence of nest of tumor cells. Nest of tumor cells along with around the nest there is presence of blood vessels. These are the blood vessels. Classical image bache, pheochromocytoma. It shows it, this is pheochromocytoma. Now they on potassium dichromate's gross incubation, very important. It turns the tumor dark brown. Next, we see the chromaffin cells which are surrounded by sustenicular cells. Which is the marker used for sustenicular cells? It is S100 positive. Easy to remember. Sustenicular, S100 positive versus the chromaffin cells which are synaptophysin and chromogranin positive, which are synaptophysin and chromogranin positive. So over to you.
Now let us have an overview. So this is a tumor of adrenal medulla. So whenever we talk about this adrenal medulla, there will be excess of what, students? There will be excess of norepinephrine, and also there will be excess of epinephrine. Now this is what is very important to understand the difference between paragangliomas and pheochromocytomas. Why? Because when we talk about pheo, both these things are seen, so both are elevated. the norepinephrine and epinephrine. Why? Because for conversion of norepinephrine to epinephrine, we require an enzyme which is known as PNMT. PNMT. Yeah. So this enzyme is present in the adrenal medulla. When we talk about the paragangliomas, they are that very same origin cells. They have norepinephrine, but epinephrine is not present here. Why? Because they lack this PNMT. So PNMT is not present here, it is present here. Now the only exception to this is organ of Zucker-Candle, because actually if you see, they were the people who would have formed the adrenal medulla, but anyhow they went late, and that is why organ of Zucker-Candle can produce you both. So paragangliomas associated with organ of Zucker-Candle will have both elevation of norepinephrine and epinephrine. So if you see, this will cause sympathetic stimulation, and thus the first thing that will have, always understand this is an endocrine organ, so pulsatile release of hormone, and since there is a pulsatile, whenever this hormone is released, there will be hypertension, and that is why this type of hypertension is known as paroxysmal or episodic hypertension. Point number one. The second is there will be palpitation. You know why it is palpitation? Because excess sympathetic stimulation. Along with that, there is sympathetic stimulation, so diaphoresis, and then blood pressure is increasing, so headache. And this is the classical presentation. Whenever we have this kind of profile of a patient, we always, like palpitation, episodic hypertension, diaphoresis, we always think that it could be FEO. Now here is what you people create a mistake. What is that? I will tell you. You people say, okay, investigation of choice for pheochromocytoma is MRI and light bulb sign. But use your common sense. This is an endocrine organ, and the investigation will be always related to the biochemical product or its byproduct. And the most stable byproduct is the metanephrines that we see at the level of urine. And why we mug up, we say 24-hour urines. But you have to understand, if one point of time you take the urine, there could be possibility at that time the hormone was not secreted out. So you'll miss out. And that is why the first line investigation is plasma metanephrine. So whenever you have such a profile, you will go for plasma metanephrine. Now you will say, sir, you are saying urine metanephrine, now you are saying plasma metanephrine. But if something is there in the urine, has to be present first at the level of plasma. So if plasma metanephrine is negative, the only value is negative, high negative predictive value. So if it is negative, then what is ruled out, students? FEO is ruled out. If plasma metanephrine is positive, then you have to go for investigation of choice, that is 24 hours free metanephrine. This is what is very, very, very important. And if this is found to be positive, the FEO is confirmed. Now, if this stands in equivocal range, what do you mean by equivocal range? This is what is very important. Neither too high, neither too low. You will say, what is this? But try to understand, your normal body will also produce catecholamines. So definitely you will also have some level of metanephrines. One fine day you had a fight with your friend, you had a fight with your girlfriend. So you are sympathetically stimulated. हो सकता है कि उसमें भी आपके hormones ज़्यादा हो. So definitely you will have elevated level, but not to an extent that you can say it's a FEO. So there is a difference. Did you had a fight? Are you under stress? So in that case, go for clonidine suppression test. Why clonidine suppression test? Because clonidine will suppress your brain, but not the tumor. Because tumor is like Kim Jong-un. मुझे फर्क नहीं पड़ता. I will do my level best. I'm not under any influence. Are you getting this? So if you go for clonidine suppression test, what happens, students? This is going to decrease the cranial sympathetic outflow. So if it is positive, that means the FEO is ruled out. Are you getting this? If clonidine suppression, so levels are persistently elevated, the clonidine suppression is negative, then it means you are dealing with FEO. So urine metanephrine comes into action once the plasma metanephrines are done. So once you have diagnosed, so diagnosis is confirmed. Now what to do? Now the next is you have to locate. So for localization, whether it is FEO versus paraganglioma, the investigation of choice is MRI. If MRI abdomen, suppose if MRI abdomen is negative, that means you are dealing with paraganglioma, and for that you have to go for DOPA PET scan. DOPA PET scan nowadays, DOTA TATE scan is also there. So DOPA PET scan is far better than MIBG, and once you have diagnosed and localized, now you have to plan surgery. Now do you know, whenever we talk about surgery, we always keep on saying, yaar, ye anesthesis aisa hai, ye waisa hai. Particularly, I'm not against anesthesis, but anesthesis keep on, like Narad Muni, they keep on blaming surgeons for everything. and telling everywhere the story of surgeons, and similarly we also keep on blaming anesthesists. But this is the place where both surgeons and anesthesists are on the high alert. Why? Because you're going to touch a hand grenade. Imagine a hand grenade where at any point of time you remove the pin, what will happen? It will blast. So when you're touching the, you can say FIO, at any point of time there will be a massive surge of the catecholamines resulting in malignant hypertension. So pre-operative preparation is very important. And when we talk about pre-op preparation, you have to start with alpha blockers. Remember, alpha blockers are started 2 weeks before, prior to surgery. And then we need to understand that these catecholamines can have a sympathetic stimulation on the heart resulting in arrhythmias. So beta blockers are added, and then we plan the surgery, and post surgery suddenly all the sympathetic tone is lost. So in that case, post surgery you require alpha agonist support. Student, I tried to summarize it ASAP, but I will take some other session, some other day. We'll have a lot of discussion on this.
Next. So another, I think last year November INI question. Patient presented with 2.5 centimeter neck swelling, which is non-tender, moving with deglutition. That is, it's a thyroid swelling. TSH, T3, T4 are normal. Ultrasound reports the swelling to be cystic and regular with a low suspicion of malignancy, which is the next step in management. Now, firstly, before we go on to the FNACs of the thyroid, what is the adequacy criteria of a thyroid FNAC? This was the question that was asked in INI. But we need to have at least 6 groups. We need to have 6 groups of follicular cells with at least 10 cells per group. So thyroid follicular cells are present in clusters. 10 cells per group, at least 6 such clusters, firstly. Except, very obvious, suppose I just had 2 groups, each with 8-10 cells, but I am able to diagnose it as a malignancy. I know that it is malignant, I cannot give it inadequate at that time. So if a diagnosis of ATP or malignancy is made, but if diagnosis ही बन गया है, then I will not call it as inadequate, firstly. Secondly, when I aspirated, then there was abundant thick colloid. I aspirated 8 ml, 10 ml of thick colloid. In that case, it is a benign lesion. I will not say it as inadequate. And lastly, if there are abundant inflammatory cells, again making a diagnosis of thyroiditis. So 6 follicles, each with 10 cells, until मेरा malignancy का diagnosis बन गया. I have a diagnosis of a malignancy. I have a diagnosis of a benign lesion showing thick colloid. So if the next level of question comes, examiner can show you this FNAC slide. See, जो पीछे छोटे cells नजर आ रहे हैं, all these small cells are the RBCs. It's a hemorrhagic sample. I am not able to see any thyroid follicular cells in this. So is it inadequate? No, you are able to make out these thick colloid clusters, making this as a benign lesion, versus if I'm able to see cells with prominent nucleoli, that means large cells, large nucleus, prominent nucleoli, that makes it as a malignancy. So this was with respect to FNAC. Now, before I come on to the Bethesda classification of thyroid, which is again important for INI, our upcoming INI exam, I'll hand it over to the sir for low suspicion of malignancy.
Let me tell you something from the beginning. Suppose a patient came to me with a neck swelling. So whenever we talk about neck swelling and there is a suspicion of thyroid, we always keep the differential diagnosis of thyroid swelling as well as a thyroglossal duct cyst. So there are a lot of things that you need to understand in that. So in this question, it is fairly written that the swelling moves with. So if the swelling moves with deglutition, this is what is very important because everything is included under the pretracheal fascia. So if it is moving with deglutition, we can say this could be, yes, thyroglossal duct cyst also versus thyroid swelling. But when we talk about thyroglossal duct cyst, it is connected to the base of the tongue. So with the protrusion of the tongue, so when you talk about if there is movement with the protrusion of tongue, always remember if it is moving, then that is a thyroglossal duct cyst, else it's a thyroid cyst. So this is a very simple thing that you need to understand and you will make a diagnosis that it's a thyroid swelling now based upon the scenario. Now, what is the next line investigation that we have to do? So let us talk about approach to thyroid swelling. So when we talk about approach to thyroid swelling, what is the standard of the investigation? We will go for USG guided FNAC nowadays. So the investigation of choice is of course FNAC. Like sir was telling you that okay, this sample is adequate, this sample is inadequate, there was hemorrhagic aspiration, there was colloid aspiration. You know that thyroid nodules may be solid, may be cystic, may be heterogeneous, may be homogeneous. So why we have added USG? In order to decrease the false negative reporting, and this is what is very important with respect to the blind FNACs. There is very important advantage that we have with USG guided FNAC is that simultaneous assessment that we have done, and along with that precise localization. So when you're doing USG assessment, so you can also tell based upon the USG findings that what are the features suggestive of malignancy. I can have it from the audience, you can also type. So I hope you see the orientation of the gland. If you see the orientation of the gland, it is more flat than tall. So if you have something in the, you can say something in the gland being more taller than wide. So taller than wide, this is one thing. Presence of microcalcification, this is one thing. Presence of internal vascularity is one thing. And then irregular borders, this is one thing. So these are the classical things that you can see, and then invasion into the local structures is again. So this is what is USG guided assessment of the FNA. Sorry, USG guided assessment of the thyroid swelling. Now one more thing, there are certain clinical features also, or clinical, you can say there are certain history features that we are going to inquire about. What is that? Whenever we talk about the thyroid cyst or thyroid nodule, remember, thyroid nodules, if you talk about gender, it is seldom seen in male. Listen to my words. Thyroid swellings are seldom seen in males. If they are seen in males, they are seldom benign, and this is what is very important. So when you talk about the risk of malignancy, it is seldom benign in case of males. Next is, when you talk about tumor size, always remember, or don't say tumor right now, say size. The logic is thyroid nodules more than 4 centimeter size, they are seldom benign. Then talk about the age, bimodal distribution. Thyroid swellings are seldom seen in kids. If seen, they are seldom benign. Rule this. This is what is very important. So this is a very important rule. 15 years and more than 40 years, both of them increases the risk of malignancy. Then history of radiation. Now, since most of them are females, you will not ask, were you born in Hiroshima, Nagasaki, or are you relatives from Hiroshima, Nagasaki? No. Females are more cosmetically oriented, not like us. So you will ask, have you ever gone any treatment for acne, or have you ever gone any hair removal treatment? So that is the place where they are exposed to radiation. This is what is important. It's a slow poison. Second or third decade after the exposure, you get risk. And then thyroid scan. You know, someone has rightly said that empty mind is devil's workshop. And someone who is a busy person is not going to help you with all those malignancy things. So if you see the functional status, cold versus hot nodule. So cold nodules, 20, or the data is 15 to 20% of the cold nodules are what? Malignant in nature. And when you talk about hot, less than 5% of them are malignant. So once you have done USG guided FNAC, we would like pathologists to tell you something about the Bethesda's. What is it? Sir will tell you about that.
True. So coming over to the Bethesda classification. When we talk about any thyroid FNAC, see, thyroid FNACs, they form our bread and butter. So when we talk about thyroid FNACs, we classify Bethesda into 6 categories. See, one is non-diagnostic or unsatisfactory. If it is unsatisfactory, if first time it was done blinded, then second time we could go for FNAC guided. So repeat FNAC with image guidance. If first time itself was FNAC guided, we'll again repeat that. 2 is benign. Clinical follow-up, nothing major is required. 3 is atypia of undetermined significance, or follicular lesion of undetermined significance. Whenever we have an undetermined significance, we'll always go for the surgeon's opinion that whether he wants to perform a lobectomy, depending upon the criteria that sir mentioned with respect to age, size, ultrasound guided features, or whether he wants a repeat FNAC. Next, 4 is follicular neoplasm. You very well know that we cannot diagnose follicular adenoma versus carcinoma on FNACs. You know that. So in that case, go for lobectomies. Fifth is suspicious for malignancy, lobectomy or thyroidectomy, as the indications have already been discussed. And lastly, six is malignant, which we expect a question to come in this INI exam on thyroid, which is does the workup, the clinical features, differentiating between the ultrasound guided, all this, that. Have a good look at this. Have a good look. Important. Next. So I guess gene mutation
This
associated.
is more of a pathology.
I agree. So associated with this renal tumor, examiner has already told you that it is a renal tumor. We see the presence of plant-like cells. See, I'm not getting into the fact that if nothing is written, before I come to the image, if nothing is written, we mean the clear cell or conventional RCC, which is associated with VHL gene mutations, von Hippel-Lindau gene mutation present on chromosome. How many alphabets are there in VHL? 3p, short arm of chromosome 3. Next is the papillary RCC, papillary or the chromophilic RCC, which is associated with chromosome 7 or CMET mutations. And lastly is the chromophobe RCC. The name tells you it is phobic of chromosomes. उसको डर लग रहा है ना chromosome से? It is phobic of chromosomes. So this is associated with deletions or hypodiploidy. I am not getting into the fact that VHL gene mutations, other than clear cell RCC, is also associated with cerebellar hemangioblastomas and pheochromocytomas. Separate day, separate topic. Not today. Not today. I am not getting into the childhood syndromes associated. Have a look at this image. This shows the presence of plant-like cells. That is, you are beautifully able to make out clear cellular borders. The cellular borders are clear with a central nucleus and perinuclear clearing. This is classical image of chromophobe RCC. Again, a very, very important image, chromophobe RCC, which is associated with, answer बच्चे, chromosome 6 deletions. इसमें do not go for chromosome 7 mutation because chromosome 7 or CMET mutations is, नहीं, that is where you went wrong. Chromosome 7 or CMET बच्चे is associated with papillary RCC, not chromophobe, as was the case in this. And lastly, just for completion's sake, let us have a look at the examiner didn't give you anything except that this is a renal biopsy, or he can give you a surgical specimen of kidney with presence of a large lesion in the upper lobe, showing the presence of cells present in NES with well-defined cytoplasmic borders, clear cytoplasm. This is the clear cell or conventional RCC, which is associated with chromosome VHL, that is chromosome 3p mutations.
Now students, I would not add lot of things to this. I would add one very important thing, that whenever we have the chromophobe RCC, now here you are having a slide, but do you know, since we don't go for renal mass biopsy, RMB in every case, we don't go for FNAC, the first thing is that based on the CT. So on the CT scan, the chromophobe RCC is playing a cat-mouse game with oncocytoma. Now there's a hell lot of difference, because oncocytoma is a benign tumor and this is a malignancy. So the prognosis and the diagnosis both will actually change the patient's life, and hence we give a benefit of doubt to the patient, and we, in fact, that oncocytoma is a benign condition, we go for we go for nephron sparing surgery or partial nephrectomy. Why? Because the patient, it's better to remove that risk out rather than keeping that risk of cancer inside, because majority of the renal tumors might be the malignant one very important thing. So sir, I hope you know that whenever we have a diagnosis in doubt, we always use one stain. And can we I will discuss with you, don't worry. So can anyone tell me that name of that stain that is of hallmark importance here? That is Hale colloidal iron stain. So when we talk about Hale colloidal iron stain, this is a chromophobe RCC that typically picks up this stain, and we go for. Now I will quickly discuss the composite management of RCC here for you. So 2-3 important points and a composite flowchart based management. The first is the investigation of choice for RCC. So the investigation of choice for RCC is nothing but a CECT. RCC with venous extension. The answer is we can actually go for MDCT also, multi-detector CT scan, or the book says MRI is the better answer. Anyways, so MRI is what we go for. Then we have the staging of RCC. You know that T1 is a tumor which is less than equal to what centimeter? 7 centimeter, of which we have T1A which is less than equal to 4 centimeter. T1B is more than 4 up to 7 centimeter. What is the significance? Less than 4 centimeter we generally go for partial nephrectomy, and more than 4 we go for radical nephrectomy. But this is not the rule. We have a score which is known as renal score, which is of paramount importance merely on the fact that you have a size criteria. You cannot. So if it's a unilateral kidney, single kidney, if it's a contralateral disease kidney, in that cases, or if there is a pre-existing CKD, you will go for the partial nephrectomies. Along with that, what is renal score? R for the radius, so tumor size, E for whether it is exophytic or endophytic. Again, this is deciding. Then N for the nearness to the, you can say, collecting system. A whether it is antero-posterior, and L is location with respect to the pole. This is what is renal score. That helps us decide whether we go for partial or radical nephrectomy. Then we have T2 more than 7 centimeter. Again, we have a further bifurcation of T2A and T2B. What is T2A, students? More than 7 up to 10. Now you will say, why doctor, why this is, sir, why are you telling me this? Shall I remember? I'll tell you one very important thing. Nowadays, since I am a laparoscopic surgeon, majority of the patient wants a laparoscopic nephrectomy or laparoscopic surgeries to be done. So you should tell them that beyond size of beyond the size of 10 centimeter, or T1B, T2B beyond, T2A beyond, you cannot go for laparoscopic nephrectomies, and this is what is very, very, very important. Then T3 is into the renal sinus. It is into the IVC. This is what is very, very, very important. Or you can say into the perirenal fat. I'm not going to that fact that above the level of liver, below the level of liver. No. T4 is into Zerotas fascia, ipsilateral I'm talking about. Or students, it is into the ipsilateral adrenal gland. Now let us quickly have a look at the management of RCC. So when we talk about the management of RCC, the gold standard nowadays is considered to be the surgery. This is what is very, very, very important. And in surgery, I have already told you whether we go for partial or radical. I have told you. But the question is, sir, when you go for partial nephrectomy versus radical nephrectomy, what are the important things that you need to understand? What will you remove? Remember, in partial, you can remove anything, but spare the minimum level of functional kidney, and that is more than 20% of the kidney should be spared. Next is when you talk about radical nephrectomy, what are the things that are removed? We remove the kidney, yes. You remove the paranephric fat, yes. You remove the lymph nodes from crust to bifurcation, yes. You remove the Zerotas fascia, yes. Will you remove the adrenal? No. That was the point that I wanted to discuss. We don't remove adrenals always, only in case if it's an upper pole tumor or if the adrenal is directly involved. This is what is very important, and along with that, the abdominal part of ureter is also removed. Next is post-surgery. What is the management? Answer is chemotherapy. Will you go for radiotherapy? No, since they are radio-resistant. Chemotherapy, sorafenib. So we give 4+2 cycle pattern, where 4 weeks therapy, 2 weeks off, and into multiple cycles. Some are sirolimus or temsirolimus also, because you know mTOR inhibitors can be used here. Now, sir must be knowing that clear cell cancers, they have lot of immunological support, and that is why we can use immunotherapy also for them. Apart from that, what is the another thing that we have? We have ablation for them. In ablation, we have cryo, which is the standard preferred. We have HIFU, and there are a lot of people who used to say radio frequency ablation. We don't. In the detailed discussion of this topic is beyond the scope. And remember, when we talk about HIFU, cryo, we need to understand that tumor size more than 4 centimeters is an absolute contraindication. And the third is for the low suspicion tumors like oncocytoma, we are fearing that it is benign versus malignant. So we can go for active surveillance. So if you have a patient who is elderly, not fit for surgery, or if you have a low suspicion tumor, you can go for 3 to 6 monthly CT or MRI. And the moment you see that the tumor is changing the texture, you can always go for the surgery. So this was all about the RCC that I could have discussed with you in that short span of time.
Done. So, sir, this gets us to a last question for this session. That is, let's have a look at this.
Just look at the, you can
The
see question
image.
and diagnose it.
Image is itself a spotter. This, I have put this question mainly because this is more of a NEET PG pattern question, in which the previous 3 NEET PG exams each had a question from intestinal polyps and tumors. So this is of course hyperpigmentation around the oral cavity, that is Peutz-Jeghers syndrome. So diagnosis, Peutz-Jeghers syndrome, which is associated with STK11 gene mutations, firstly. Secondly, E. cadherin, we have, let's quickly have a look at the gene mutations and the tumors associated. E. cadherin, we have already discussed, is associated with signet ring cell adenocarcinoma stomach. Along with that, lobular carcinoma breast. SMAD2 and SMAD4 gene mutations. This is juvenile polyposis syndrome, and this was, I guess I have the question with me. This was last year's NEET PG question. 5-year child with bleeding per rectum. Diagnosis, juvenile polyposis syndrome. Diagnosis, juvenile polyposis. The minute you have a history of a child with bleeding per rectum, we are thinking towards juvenile polyposis, along with the biopsy given, which shows the presence of large cystic areas with glands being present back to back, associated with SMAD2 and SMAD4 gene mutations, versus the APC gene mutations, the one with the wicked disease, which is FAP, familial adenomatous polyposis, APC gene mutation. Now lastly, talking about Peutz-Jeghers syndrome, the microscopy part of the same, something to cheer us up, Christmas, that is the classical Christmas tree appearance, Peutz-Jeghers syndrome, Christmas tree appearance. I am not getting into the fact that even though hematomatous polyps are non-neoplastic polyps, but they have an increased risk of malignancy. That is, they are associated with adenocarcinomas colon, and not only the colon, but also other sites, that is testicular tumors, ovarian and pancreatic neoplasms.
Basically, if we talk about the Peutz-Jeghers, I would not take a lot of time of yours. Student sir has told you something. So first of all, it is associated with GI polyps. The next thing is, where in this? So remember, Peutz-Jeghers, it is the jejunum. And what part of the jejunum, students? It is the proximal jejunum. And do you know one very important thing? That Peutz-Jeghers increases the risk of CA, pancreas also. And this is a very famous question. How many times? Approximately 150 times. And this is the most common thing. Why? Because it is associated with a lot of duodenal adenomas, resulting in increased risk of pancreatic cancers. Apart from this, what else is? You can get to see oral or perioral pigmentation or melanosis. So perioral or oral pigmentation, you can see this is what is very common in friend. Apart from this, you also get to see penile pigmentation also in certain patients. So penile pigmentation is also there. Remember, this is actually managed by segmental excision. So segmental colectomy is what we actually, or segmental excision, wherever it is. So we go for segmental colectomy or segmental excision is what is the classical preferred management for them. So with this, we would like to summarize this session. Students, integration of subjects is very important. We have tried to get some integration in context with pathology and surgery. Same. This is a beautiful series where we will be discussing. Lot of teachers will be integrating the things. Remember, same is the way you should be studying. When you are studying a subject, try to see, like if you are studying surgery and you get something of pathology, don't think that, okay, I will not cover. Try to summarize that thing, make some notes, scribble down, add sticky notes, create that same ecosystem where you get all the subjects together. And if you start doing this in an integrated way, definitely you will find the subjects very easy, because whenever we see questions, 2 options are from pathology, or suppose one option is from anatomy, 1 from pathology, 2 are from the treatment. So this is the time when you also have to step forward and change the orientation how you used to study. Mugging up a subject is not going to give you to lead to anywhere. Understand the concepts of the topic, and LNX is there to motivate you, to help you, to guide you, to handhold you in this journey to your specialization and becoming a specialist. Do subscribe to the session, do subscribe to our channel, and do share the session links with your near and dear ones.
And actually, I mean, gone are the days when you will just have a single subject based question. You will be integrated, firstly. And secondly, I like to say this for all the exam appearing students. But you already have a beautiful NEET rank. So do not overthink. I mean, keep on working, keep on studying. Things will certainly turn out better than we expect. So on this positive note, I guess take care, and bestest of luck. Thank you.